A 68-year-old man comes to see me. His blood pressure is controlled, his readings look excellent, his doctor is satisfied. But for the past 4 months, he has been waking up at 3 in the morning with muscle cramps so severe he has to get out of bed and pace the room. He assumed it was age. He assumed it was dehydration. He assumed it was anything other than the one tablet he takes every morning without fail. It was the tablet. And the frightening part is not that his medication caused this. The frightening part is that nobody ever told him it could, or what to do when it did. That is exactly what this video is going to fix. I am Dr. Hameed Ullah Shaheen, and today I want to have the conversation that most medical appointments are too short to have properly. If you are taking Amlodipine, Losartan, or Lisinopril, or if someone in your family is, you deserve a complete picture. Not just what these medications do when everything goes right, but what your body may be telling you when something needs attention. What combinations are silently dangerous, and what the number on your blood pressure monitor is actually telling you, and what it absolutely is not. By the end of this video, you will not just be taking your medication, you will understand it. And that understanding is the difference between a patient who stays safe and one who gets hurt by a drug that was supposed to help them. The foundation. 3 drugs, 3 completely different mechanisms. Before anything else, I need to establish something that most patients are never clearly told. Amlodipine, Losartan, and Lisinopril are not 3 versions of the same thing. They are 3 entirely different interventions that happen to produce a similar end result, lower blood pressure, through completely different pathways inside your body. Amlodipine is a calcium channel blocker. It works by relaxing the smooth muscle in arterial walls, causing them to widen. Lower resistance, lower pressure. Simple and effective, but with consequences specific to that mechanism. Lisinopril is an ACE inhibitor. It blocks an enzyme called angiotensin-converting enzyme, which is part of a hormonal chain your body uses to constrict blood vessels and retain sodium. Block that enzyme and the chain breaks. Pressure drops. But that same enzyme is involved in other processes, which is why Lisinopril produces side effects that Amlodipine never would. Losartan is an ARB, an angiotensin receptor blocker. It works one step further down the same hormonal chain as Lisinopril, but at the receptor level rather than the enzyme level. Similar protective effects in some ways, but a meaningfully different side effect profile. Why does this matter to you as a patient? Because if you experience a side effect from one of these medications and assume it means all blood pressure drugs will affect you the same way, you may abandon treatment that is genuinely protecting your life, when the solution was simply switching to a different class. And because when something feels wrong in your body, knowing which drug you are on tells you, and your doctor, immediately where to look first. Point 1. Amlodipine and swelling. Why your ankles are not lying to you. Let me describe something that happens to a significant number of patients on amlodipine. They start the medication. Their blood pressure improves. Then, gradually, they notice that by late afternoon, their ankles look different. Their socks leave marks. Their shoes fit differently in the evening than they did in the morning. By the time they go to bed, their lower legs feel heavy. Their first assumption, understandably, is that something is wrong with their heart or kidneys. Here's what is actually happening. Amlodipine relaxes arteries more effectively than it relaxes veins. Blood is therefore pushed into the lower limbs more efficiently than it is returned. Pressure builds in the small capillaries of the legs, and fluid leaks into the surrounding tissue. The result is what doctors call peripheral edema, and it is a direct, predictable consequence of the drug's mechanism in a subset of patients. This swelling is not heart failure. It is not kidney disease. It is not dietary excess. In many cases, it is simply the cost of how this particular drug works in this particular person's vascular system. Why does this matter beyond comfort? Because patients who do not understand this do one of 2 dangerous things. They either panic and assume something catastrophic is happening and make impulsive changes to their medication without medical guidance, or they normalize it entirely, never mention it, and quietly develop skin changes and discomfort that could have been addressed. The right response is neither panic nor silence. It is a conversation with your doctor, because in many cases, a dose adjustment, a different formulation, or a switch to a different drug class resolves this entirely. If your ankles are swelling and you are on amlodipine, that symptom belongs in your next appointment. Do not dismiss it and do not catastrophize it. Report it. Point 2. The lisinopril cough. What most patients miss about the timeline. Ask almost any physician about lisinopril side effects, and the first thing they will mention is the cough. Most patients have also heard of it. What most patients have not been told is this: the cough does not always begin in the first week. It can appear after 2 weeks. It can appear after 2 months. I have seen patients who developed it after 6 months on the medication, and because so much time had passed since they started, they never connected it. They blamed dust, allergies, acid reflux, a viral illness that had long since resolved. The cough has a very specific character when it is lisinopril related. It is dry. It produces nothing. It feels like a persistent tickle or irritation at the back of the throat that no amount of water, lozenges, or throat clearing fully resolves. It often worsens at night, disrupting sleep. And it does not respond to antihistamines, reflux medication, or allergy treatments, because none of those things address its actual cause. What is that cause? Lisinopril blocks the breakdown of a substance called bradykinin. Bradykinin accumulates in the airways and triggers the cough reflex. It is a pharmacological consequence, not an infection, not an allergy, not aging. Here's the critical clinical point I want every patient to understand. A cough on lisinopril, while miserable, is not medically dangerous in itself. What is dangerous is a different reaction, one that is rare but serious. Swelling of the lips, tongue, throat, or face. Difficulty swallowing. A sensation of the airway tightening. This is called angioedema, and it is a medical emergency. It requires immediate care, not a phone call to the clinic, not a wait-and-see approach. Emergency care. The distinction is important. A cough, report it. Discuss alternatives. Swelling of the throat or tongue, move immediately. And one more thing about the cough. If you are experiencing it and finding it intolerable, do not simply stop your medication. Speak with your doctor. Losartan, the ARB, was specifically developed as an alternative for patients who cannot tolerate the ACE inhibitor cough, because it works on the same hormonal system without accumulating bradykinin. There is a pathway forward. Point 3. Potassium. The silent danger in your kitchen. This is the point in the conversation where I need your complete attention, because this particular danger hides in places patients never suspect. Both losartan and lisinopril work partly by reducing the activity of a hormone called aldosterone. Aldosterone normally tells the kidneys to retain sodium and excrete potassium. When you block aldosterone's effects, less potassium leaves the body. Blood potassium levels can gradually rise. In most healthy patients with normal kidney function, this rise is modest and manageable. But in patients with reduced kidney function, which includes a significant proportion of people over 60, the rise can be more significant. And in patients who are simultaneously adding potassium from external sources, the combination can become genuinely dangerous. Where is that external potassium coming from? This is what surprises patients most. Salt substitutes. This is the biggest hidden source. Many popular salt substitutes, sold specifically as heart-healthy, low-sodium alternatives, replace sodium chloride with potassium chloride. A patient who switches to a salt substitute in good faith, trying to protect their heart, may be significantly elevating their potassium intake while on a medication that is already raising potassium levels. high-dose potassium supplements, sports electrolyte drinks and powders, certain herbal preparations. What does high potassium feel like? That is the other problem. It often feels like very little until it doesn't. Mild muscle weakness, occasional cramps, a tingling or numbness in the hands or feet, fatigue that seems disproportionate, and sometimes, disturbingly, an irregular sensation in the chest, because elevated potassium affects the electrical system of the heart. The practical guidance is clear. If you are on Losartan or Lisinopril, do not switch to a salt substitute without discussing it with your doctor first. Do not take potassium supplements without explicit guidance. And if you develop unexplained muscle weakness, cramping, or palpitations, your potassium level should be checked promptly. Point 4. What illness does to your medication. This is the piece of information I wish every patient on Losartan or Lisinopril was given the day they started their prescription. These medications, in a healthy person with normal fluid balance, work as intended. But your body is not always in that state, and when it is not, the same dose of the same medication can behave very differently. Vomiting, diarrhea, fever with heavy sweating, a stomach illness where you cannot eat or drink normally for 24 hours, hot weather with significant fluid loss. Any situation that reduces your body's fluid volume changes the equation. When you are volume depleted, meaning your circulating fluid is reduced, these medications can lower blood pressure more aggressively than intended. The kidneys, which depend on adequate blood flow to function, can come under stress. What was a safe dose yesterday can cause dizziness, near fainting, and in some cases, early signs of kidney strain today. This is not a reason to avoid these medications. It is a reason to have a specific plan in advance. Ask your doctor, before you need the answer, what you should do if you become ill and cannot take fluids normally. Ask whether there are circumstances in which you should temporarily hold your medication and seek guidance. Ask what symptoms should prompt you to contact someone rather than simply continuing your usual routine. Having that plan costs nothing. Not having it, when you need it, can cost a great deal. Point 5. The interaction nobody thinks to mention. Here is a scenario that plays out in thousands of patients every year. A patient is on lisinopril for blood pressure and perhaps a diuretic for fluid management. They develop knee pain, back pain, or arthritis flare, common complaints in the same age group managing hypertension. They go to the pharmacy and buy ibuprofen or naproxen because these are available without a prescription and have been used their whole life without incident. What they do not know is that this combination, a CE inhibitor or ARB, plus a diuretic, plus a non-steroidal anti-inflammatory, creates a specific physiological situation that can reduce blood flow to the kidneys. In a younger person with robust kidney function, this may cause no perceptible problem. In an older patient, particularly one with any baseline reduction in kidney function, it can accelerate kidney stress significantly. The anti-inflammatory is not automatically forbidden. The clinical picture is more nuanced than that. But it is absolutely not a casual decision, and the reason patients get hurt is that nobody told them to make it a decision at all. They thought it was just a painkiller from the drugstore, not a drug interaction worth reporting. The rule I want you to take from this is simple. If you are on Losartan or Lisinopril, over-the-counter anti-inflammatory medications are a topic for your doctor, not a decision made at the pharmacy shelf. Ask about safer alternatives for pain management in your specific situation. Point 6. Dizziness is not something to walk off. All three of these medications, particularly when first started or when doses are increased, can cause blood pressure to drop more than intended in certain positions. The clinical term is orthostatic hypotension. The pressure falls when you stand up. Blood pools momentarily in the lower body before the vascular system compensates, and the brain receives slightly less blood for a few seconds. You experience this as dizziness, lightheadedness, or that woozy, unsteady feeling immediately upon standing. In a younger person, this is uncomfortable and usually brief. In an older adult living independently, it is a fall risk. And falls in people over 65 are not trivial events. They are leading causes of serious injury, hospitalization, and loss of independence. What I want patients to understand is that this symptom has a cause, and it has solutions. Rising slowly from a seated or lying position, sitting on the edge of the bed for 30 seconds before standing, ensuring adequate hydration. These are not minor suggestions. They are the practical application of understanding how your medication works. If the dizziness is persistent, not just the first few days, or if you have experienced a near fall or actual fall, that is urgent clinical information. It may mean the dose is too high for your current physiology. It may mean another medication is compounding the effect. It may mean your blood pressure is now being controlled too aggressively. Persistent dizziness is not something to simply endure. It is a signal that the current treatment plan needs review. Point 7. The blood pressure reading you are misreading. I want to talk about something that causes enormous unnecessary distress and genuinely dangerous impulsive decisions. Patients checking their blood pressure at the wrong times and drawing the wrong conclusions. Blood pressure is not a fixed number. It fluctuates constantly throughout the day in response to activity, stress, pain, conversation, posture, caffeine, food, sleep quality, and even the anxiety of measuring it. A reading taken in the first moments after waking, or immediately after an argument, or while worried about a symptom, or in the middle of a stressful afternoon, is not representative of how your medication is performing. What matters is pattern. Consistent readings, taken at the same time each day, after 5 quiet minutes of rest, in the same position, with a properly calibrated device on the upper arm, not the wrist. Patients who check their pressure reactively, every time they feel a headache, every time they feel anxious, every time they read something alarming, generate a dataset dominated by stress response readings. They then present those readings as evidence their medication is failing. They take extra doses, they skip doses, they demand medication changes, and sometimes they create the blood pressure instability they were trying to avoid. Your medication should be evaluated by trends, not individual readings. If you are unsure whether your readings are telling a meaningful story, bring your log to your appointment and review it together. That is far more useful than either panic or false reassurance from a single number. Point 8. The most dangerous thing a patient can do: nothing. I want to close with something that cuts across every point I have made today. The patients who get hurt by these medications are rarely the ones who ask too many questions. They are almost always the ones who stay silent. Silent about the cough that has been disturbing their sleep for 3 months. Silent about the ankle swelling they are managing with compression socks rather than a conversation. Silent about the dizziness they had last Tuesday that scared them, but then passed. Silent about the salt substitute they switched to 6 weeks ago because they thought they were being heart healthy. Silence feels like compliance. It feels like being a good, uncomplaining patient. In blood pressure management, it is the opposite of safety. Your symptoms are clinical data. They are not complaints. They are not weaknesses. They are information that your prescribing physician needs in order to make good decisions about your care. A dry cough that is destroying your sleep is not something to live with indefinitely. There are alternatives. Ankle swelling that is worsening over weeks is not something to attribute to age. It has a cause, and it has solutions. Muscle cramps waking you at night are not something to dismiss. They may be telling you something important about your electrolyte balance. You do not need to arrive at your appointment with a diagnosis. You need to arrive with an honest account of what you have been experiencing. The rest is your doctor's job. What to watch for on each medication. Let me give you something concrete to keep. If you are on amlodipine, watch for ankle and lower leg swelling that worsens through the day, flushing of the face, headaches in the first week or two, and dizziness when standing. If you are on lisinopril, watch for a persistent dry cough at any point after starting, dizziness, and most urgently, any swelling of the lips, tongue, face, or throat, which requires immediate emergency care. If you are on losartan, watch for dizziness, muscle weakness or cramping, unusual fatigue, and palpitations, and pay close attention to anything adding potassium to your diet. For both losartan and lisinopril, blood tests are not optional. Kidney function and potassium need to be monitored, especially when starting, when doses change, and when anything in your health or routine changes significantly. For all three, illness that reduces your fluid intake is a reason to contact your doctor rather than simply continuing as normal. The goal of blood pressure medication is not a number. It is a life, lived with stability, with safety, and with the confidence that comes from understanding what is happening in your own body. Amlodipine, losartan, and lisinopril are genuinely effective, genuinely protective medications for the right patients. But they are powerful drugs operating in a complex physiological environment, and they deserve and require an informed patient. You are now better informed than you were 12 minutes ago. Share this video with anyone in your family who is managing blood pressure with any of these medications. It may prompt a conversation that protects them. Leave a comment below. Tell me which of these medications you are on, and which point in this video gave you the most to think about. I read every comment and I respond. I am Dr. Hameed Ullah Shaheen. Take care of yourselves, and take your medications with understanding, not just obedience.